Hi, everyone. I hope you are enjoying the conference so far. I am Donna Levin, National Director for the Network for Public Health Law, and I am extremely happy that the time has come for our keynote. It is truly an honor for me to introduce our keynote speaker, Dr. Deborah Prothrow-Stith. Dr. Deborah Prothrow-Stith is a graduate of Spelman College and Harvard Medical School. During her career, she has served as Commissioner of the Massachusetts Department of Public Health and as Professor and the Associate Dean of Diversity at the Harvard School of Public Health, where she created a division of public health practice. Dr. Prothrow-Stith is currently Dean and Professor at the Charles R. Drew University College of Medicine. She has been a pioneer in the recognition of youth violence as a public health problem, and since then has been breaking new ground with her leadership on this front. She developed and wrote the violence prevention curriculum for adolescents, paving the way for violence prevention curricula in schools and communities. She has authored and co-authored numerous publications, including Deadly Consequences, the first book to bring a public health lens on violence to a wider audience. And today she will share her reflections and lessons learned from her work in violence prevention. It is impossible to cover our keynote speaker's accomplished career to date adequately in a brief introduction, so I encourage you to learn more and to take advantage of the time for questions following the keynote. I will look for them in the chat box. On a personal note, I want to add that Dr. Prothrow-Stith was the first woman commissioner for the Massachusetts Department of Public Health. During her tenure, she established the nation's first Office of Violence Prevention in a state Department of Public Health, expanded prevention programs for HIV/AIDS, increased drug treatment and rehabilitation programs, and appointed me to be the department's general counsel, for which I will be forever thankful. Having had the opportunity to work with Dr. Prothrow-Stith, I know firsthand what a wonderful, effective, and passionate public health leader she is. And now it is very truly my great pleasure to welcome Dr. Deborah Prothrow-Stith.
Well, thank you. Hello, everyone. And I just want to let you know that I am honored to be here because the interface between the law and public health, particularly on this issue of violence, is so very, very important. And I have to thank Donna for not only that wonderful introduction, but for all that she does in the organization and in her work. So thank you. I'm honored to be here and looking forward to our discussion. I am planning to do a little bit of history here. It was 1978 when a young man in the emergency room, when I was a student, a third-year medical student, the young man told me after we had stitched him up that he had been at a fight and he was going out and he was going to get the guy who got him. And it struck me then immediately that, we sort of, he said it with this bravado and we sort of laughed with him and he left. And it struck me immediately that he could get hurt again. And that in all my medical education to that point, prevention had been a part of my responsibility. So if it had been heart disease or where we talked about diet and smoking, or lead poisoning, where we had to make sure a house was de-leaded before a child could leave the hospital, we had prevention as part of our practice. And it struck me that we were stitching people up and sending them out and not doing any prevention. Not at that point that I understood or had any idea what prevention would look like, but our work around suicide and suicide prevention when someone had made an attempt served as an immediate platform for me to begin to think about this. And I realized that had he made a suicide attempt and said, don't go to bed, I'm going to go home, I'll take some more pills, and I'll be back in this emergency room, we would have responded very differently. And that we had a protocol and we had people to call, the psychiatric nurse and even the psychiatrist. We could commit people against their will to hospitalization for surveillance and treatment if we thought there was some urgency around the suicide. So using that as a platform, I started thinking about this problem and wondering, what should we do? Subsequently, I learned from the MMWR from CDC, the Morbidity and Mortality Weekly report, again, this is back in the late 70s, early 80s, that homicide was a leading cause of death for young Black men, and the second leading cause of death at that time for all teenagers. At that point, I felt a little angry and betrayed by medicine because I had gone to medical school to treat and work with teenagers. That was my plan. And the leading cause of death had not even been discussed. So that anger and that, set of questions really kind of fueled my reaching out to CDC, where I found Mark Rosenberg, who was heading up the violence epidemiology branch there. And I found Larry Cohen, who was out here in California working in Contra Costa County. I found Howard Spivak, who became a colleague and writer, co-author with me. And there was this growing group of people saying, why are we stitching people up and sending them out? Why don't we have prevention protocols? And in 1985, then Surgeon General Koop hosted what we think is the first conference on violence as a public health problem. And we were broken down into the different kinds of violence, school violence, elder abuse, intimate partner violence, gang violence, street violence. And those silos were very helpful in getting this going. They've created a little challenge or two along the way, but that conference really set the stage for those of us in public health to start in earnest, looking at the epidemiology of violence, reaching out to law enforcement and criminal justice to try to understand the relationship. And needless to say, there were quite a few early days of tension. Over time, the chart that you are viewing now emerged for me as one way of kind of understanding our roles and responsibilities. Primary, secondary, tertiary prevention really represents pretty standard public health speak about these three levels. There's also universal, selected, and targeted. I like upfront, in the thick, and after the fact. That's what some teenagers in Philadelphia, when we were working on this, put in front of us. I think it captures fairly well, in an understandable way, what we're talking about. But what we've shown here is public health's responsibility, primarily for upfront, in the thick, and a little bit of after the fact. And then criminal justice responsibility, a little bit of upfront, in the thick, is shared, and after the fact. And it was very, well, actually, it is still very helpful to me to kind of keep this model in mind. I was once asked, when we were doing the violence prevention curriculum in high schools in Boston, I was asked, how could I expect a gang member who shot someone to benefit from conflict resolution and anger management and what we were doing? And the answer is, well, there may even be some benefit because those who've gone into prisons in particular often hear things like, well, I never thought about or never talked about, nobody ever shared with me some other strategies. So there may be some benefit in that situation, but it's pretty clear that a gang member who shot somebody is in need of much more after the fact intervention rather than upfront. I want to say that in the thick is where I still don't think we do a very good job. Public health, law enforcement, criminal justice, I think we are missing a lot of opportunities to spend resources and time and energy on the kid who is hiding under the sofa, who watched his mother beaten over the weekend, or the kid whose older brother is in jail and the next older brother is on trial. And that kid is sitting there with the family. There are many efforts that could be increased. For instance, we know that Big Brother, Big Sister is an effective intervention, particularly in the thick, especially early on, and certainly up front. And that may be a resource that we need to make available as soon as we see that kid. A kid whose cousin was shot and killed, a cousin that lived with them, is expected to, go back to school and behave like all the other children. And when that kid starts misbehaving, we start a punishment cycle. So that I just want to highlight that because I think this interface between our two disciplines, if you will, is critical, and a lot more work has to be done. When we were making the case and convincing law enforcement to join us and talk about, this kind of joint effort, these were the reasons: the magnitude of the problem, the toll it takes on life and limb, the characteristics of the problem, which surprised me. I was, I think like most people, thinking that the violence was executed by some stranger bad guy who came from some alien place and hurt innocent people. But I was surprised to learn that there was a significant family, acquaintance, associate, friend components to almost every kind of violence. We argued because of the contact that the health professionals had, we needed to have some response. And then we were making an assumption that the same things we were doing for drunk driving or teenage pregnancy, or even lead poisoning for that matter, that those public health strategies, the passage of laws, the education in the classroom, the peer-led activities, that would help with this issue of violence. And fortunately, over time, we've learned that there is some reason to do this. I show you this slide because it sort of illustrates what impact public health can have and has yet to have with firearm violence. The blue line represents motor vehicle accidents, crashes, not accidents. We know that there's injury and automobile crashes, but that decline really represents a lot of work. Some looking at the causes, some looking at the drivers, drunk driving responses, a lot of manipulation of the car to make it safer, laws to make it safer to drive, street lights, lots of things led to that. But the comparison here with firearms and deaths from firearms, I think, is illustrative of where we have yet to get relative to this this problem. And the Daily News sort of captured it. 30,000 people, 804 people die in car accidents, and Congress approves more than 830 million for safety research. 33,636 die by guns, and these frauds sign off on a paltry 5 million. I think we really are in a situation where there are still things that we need to do, more of, and we can have a better impact on this problem if we do some of those things. One of the things that I learned early on that was also surprising, not just the characteristics, two people who know each other, who get into an argument, who are drinking and who have a handgun, and how those defy a lot of the legal and law enforcement strategies. But I also was surprised to learn that there are more suicides than homicides each year in the United States, by about twice as many. That surprised me because of the differences in the demographics between homicide and suicide, and also started me thinking about adolescent homicide and suicide and the potential similarities that are there. And if you look just by race, the demographics of the two are strikingly different. If there are gun deaths to African Americans, they are most likely by homicides, 82%, but gun deaths to whites are about 77% suicide. If you work with adolescents, you learn that precipitants for suicide or suicide attempts can be very similar to precipitants for fights or homicide. The involvement of drugs, alcohol in particular, the involvement of peers, and the momentary nature of the crisis that teenager is experiencing, but the narcissism developmentally that teenagers experience make it not seem momentary at all, and make it seem as if all the eyes of the world are watching. I think there's a reason to think more carefully about the similarities between these two. And obviously the presence of the gun is something that is worth considering in both situations. I found it often that a street outreach worker in urban America would say something like, that kid really didn't care anything about himself, so it's not surprising that he shot somebody. Well, not caring anything about yourself is a symptom of depression, and it's often overlooked and missed in that setting, where there's this bravado or the stereotypical portrayals that many workers have. I think we have to explore this a little bit more if we really want to reduce gun deaths in America. Suicide and homicides here are displayed high suicide rates per 100,000 on the x-axis and high homicide rates per 100,000 on the y-axis. And this is a distribution of states. And there are states like Montana with very low homicide rates, fairly high suicide rates, Louisiana with kind of a high homicide rate and probably a medium level or middle level suicide rate. Obviously, there are ways that this implies there are differences between homicides and suicides. I also think, again, the similarities lie maybe in the cultural response to issues in life, whether it's the list I made or stress. We should learn more about that, because I think as a violence prevention community, it actually brings together a broad set of constituents. I want to talk a little bit about guns. And in this kind of historical look as well. So in 1993, in the early 90s, we were beginning to get some very good publications. This one in the New England Journal, the one that looked at having a gun in the home as an independent risk factor. And we were getting survey information about why people had guns. A lot was happening, and a lot of this was funded by the Centers for Disease Control as a result of people saying, yes, violence is a public health problem, and we need to learn more, and the epidemiology can help us understand this problem and get into prevention. And there were a series of very highly visible shootings. And in 1994, we would get some early 90s getting good information, some really big nationally covered shootings. And we passed the federal assault ban. Clinton signed it in 1994. So we're getting good information. The assault ban is passed. Passing that was a big deal. The police unions worked with public health, testified for the first time around this ban for it, and things were looking up. But almost immediately, we started getting the backlash. And this is 1996 and the Dickey Amendment, which removed from CDC's budget about $2.6 million. And it was a line item scratch out of every amount where the word firearm appeared. That began, to dampen the research a bit. People felt less inclined to dedicate careers to this area. The assault ban was a 10-year ban, shown here in gray, but it was allowed to expire by Congress in 2004. And there have been some attempts to sort of understand what impact that 10-year period had. And certainly we can't say that it eliminated these mass shootings. And that's what you see in the blue lines on the chart. Because it seemed as, many occurred in that 10-year period as not, but it does look like the number of people killed in these episodes increased. And there's some speculation that in 2004, the gun manufacturers had weapons ready to flood the market as soon as the ban was lifted. So we don't know exactly what that 10-year period gave us. But I know some are, again, trying to raise the assault ban. And some of it, was just kind of logical at one point. Race is another issue in this violence prevention activity that deserves a bit more attention. We have here rates of imprisonment with African Americans in the red bar up above here. And you can see the actual rates down the side per 100,000. There's something quite stark, challenging, worrisome, tragic when we start looking at these numbers and we appreciate the history of the United States around the issue of race. I became familiar with this notion of justifiable homicide a long time ago when like in the 70s and 80s, when I first started looking at these data, and there was always this, small, steady amount of homicides at the bottom, whereas, assaults by, or homicides by intimate partner, homicides by gay, those things were higher and went up and down. But there was at the bottom this very low, steady stream of homicides called justifiable homicides. And when I read about them, this definition in front of you here, I appreciated that, if you were committing a felony, then, I didn't want you to get killed, but you shouldn't have been committing the felony. I didn't think much of it. I'm an African-American woman, grew up in the South, very much aware of police community issues, very much aware of lying police officers, very much aware of Black people not being able to rely on the police for protection. And even with that experience, I looked at these data early on and I said, it just, that is what it is. And obviously with cameras now, we are learning a lot more about those data and those justifiable homicides. This is in light blue, law enforcement officers, and in dark blue, private citizens with this issue of justifiable homicides. This is just a headline out of the Washington Post in 2017 that was looking at fatal police shootings, who was armed, what percent were African American. And, all I can say is thank goodness for cameras and telephones that have cameras on them, because it's made us understand that all of that justifiable homicide is not justifiable. With the situation with George Floyd, what I find troubling, as well as obviously the whole situation, is the 16-year-old who was walking her 9-year-old brother to the store and back home, who stopped to film this. It's not just those numbers of, 300, 400, 500 a year, but those are people who, with families, loved ones, and friends, their death has just enhanced for a young person the issues of racism, the chiasm between the police and the community. And that 9-year-old boy, the Minneapolis Police Department need to adopt him. He needs to get in the thick services. We cannot ignore him or the 16-year-old who filmed this. But this has a history, and if we want to get past it, we're going to have to do some things, including appreciate the history. This is an 1851 placard that was posted in Boston. I got a copy at the African American Museum on Joy Street in Beacon Hill in Boston. And it reads, "Caution, colored people of Boston, one and all. You are hereby respectfully cautioned and advised to avoid conversing with the watchmen and police officers of Boston. For since the recent order of the mayor and the aldermen, they are empowered to act as kidnappers and slave catchers. And they've already been actually employed in kidnapping, catching, and keeping slaves. Therefore, if you value your liberty and the welfare of the fugitives among you, shun them in every possible manner, as so many hounds are on the track of the most unfortunate of your race. Keep a sharp lookout for kidnappers and have a top eye open." So the bad blood between the police and the African American community goes back. It has a history, it has a tragic history, and it really represents in some ways the origins of the police officers. So we've got to acknowledge that, understand that, train differently, and take care of those who've already been traumatized by the policing practices. In public health, we talk a lot about these canaries in the coal mine. They were literally used to know when the air is bad, the air is bad. And I think our young men of color are just the canaries in this coal mine. I'm going to read Pastor Martin Niemöller's poem, "First They Came for the Socialists, and I did not speak out because I was not a socialist. Then they came for the trade unionists, and I did not speak out because I was not a trade unionist. Then they came for the Jews, and I did not speak out because I was not a Jew. Then they came for me, and there was no one left to speak for me." This is our collective problem. And professionally, if we understand that the police are not the only ones with the knee on the neck of African American communities, and that all of our professions, including medicine, including the helping professions, have in it, baked in it, historical racism, and we've got to be able to address it. So there are some risk factors for violence. We've talked about guns. I've talked about the issue of race and racism and how it impacts. There are obviously many other risk factors to be considered. Important ones listed here are some that we've learned from the epidemiology of studying injury and intentional injury and unintentional injury. The risk factors and the resiliency factors operate at various levels, as shown here with the concentric circle. I remember a reporter asking a man whose son was murdered, what he did wrong. He said, you did everything right. It seems you Your son was an athlete and a scholar. He was in a great school. He was well liked. It seems that you did everything right. And the father said, I forgot to do one thing. I forgot to raise the other children. It's really not enough to have a healthy child in a healthy family, even if you can get that community to be healthy. As kids become teenagers, their interactions are with a broader set, and you can get risk outside of your immediate family in a way that brings this very close to home, and in some situations, tragically. I want to talk about the last risk factor here, the culture of violence, a bit, because I've learned a lot about it. One way I started thinking about it was the increase in girls being arrested for violence, and what high school principals said to me a decade or so ago about having to call ambulances with girls fighting at the school. And the cultural aspect of this struck me because for probably about 3 decades now, we've been marketing violence to girls the way we've been marketing it to boys for centuries. Girls and boys are in the same homes. They get guns from the same places. Boys use guns more than girls, and young men use guns more. I don't know if that's a stagnant variable, but the more we market this as a cultural norm to girls, it seems that we are equalizing the advertisement, the expectations culturally of violence. Leonard Eron, a psychologist, spoke for us. This was back in the early 80s. And he said, if you want to reduce violence in America, you have to socialize your boys more like we socialize girls. And I think over the decades, we've kind of done the opposite. But an even more striking cultural issue is the one of dueling, or an issue that has implications for this cultural risk factor is dueling in America. And there was a time when, according to these authors, Fox Butterfield in particular, in All God's Children, really projected that from dueling, the rates of homicide were 18 per 100,000 in South Carolina and 17 per 100,000 in Louisiana. And duels were not random events. They were well-defined, orchestrated events, and you had to be a gentleman for it to be a duel. Interestingly, duels were about insults. And so this placard on the right that reads "To the public" is really saying that General Reed declined apologizing to William Tradewell. And he goes on to say that he's declared him a coward and a scoundrel. So for the insult and his refusal to apologize, this was a placard posted, which is the first step toward dueling, a very orchestrated set of activities in the United States that began just around the Revolutionary War and really peaked around the Civil War, declined a bit thereafter. And the last recorded one is 1940, but they were rare even before that. But during the 20s, 30s, 40s, dueling in the United States was the pastime of elite white gentlemen. And probably the most famous one was Alexander Hamilton's duel. And I did my schooling in math and science and medical school and didn't do a whole lot of history. So this I found pretty striking because Alexander Hamilton's son was killed in a duel. And then 3 years later, he was challenged to a duel by Aaron Burr. And before he went to duel, he wrote why he shouldn't and why he should. And he said he shouldn't duel because, this is in his diary, because he had a wife and children that he loved, that he was deep in debt and he didn't want to leave that debt to his wife and children, that he really had no ill will against Aaron Burr, that dueling was illegal in New York, and it was condemned by Christianity, which is his religion. So despite all that, he wrote why he should go duel, and it was a pressing necessity not to decline the call, which is just straight up peer pressure. That's what that is. That it would cost him political support. So that's, my posse won't hang with me if I don't do what I'm supposed to do. I won't have their respect. I won't have their support. And then that it's essential to his ability to be useful in the future. So it was tied to issues of status and manhood and productivity. So it was very interesting that Alexander Hamilton, a man whose son was killed in a duel, who wrote laws and understood that it was illegal, had religious and other compelling reasons not to duel, couldn't resist. And so he woke up, and the next morning he drove to Weehawken, New Jersey, and took the boat, I'm sorry, took the boat to Weehawken, and was killed in a duel. So if this, man couldn't resist with all of his status and cultural context, I'm not sure how we expect our children, particularly those in very stressful situations where the violence is around them, to resist those pressures that need to be and have a status, that need to belong and be a part of, and have the support of. So for me, this is where the challenge lies. How do we make nice popular, kind popular, forgiveness popular? How do we, because making it illegal to fight hasn't been the source of the solution. Now, there have been some looks at how dueling ended, but not very good ones. There was certainly an outcry from Benjamin Franklin, from Samuel Clemens, people, the churches, people saying this is wrong, kind of like a violence prevention movement, if you will. There's some who speculate that the Civil War cost so many lives that really represented the end of dueling. There's others who speculate that litigation replaced dueling, that insults and slander were handled in the courts, and therefore the dueling on the streets didn't occur. It's worth trying to appreciate that and understand that. I think cultural expectations are part of what we have to consider if it's considered a cowardly thing to do to litigate a situation or take someone to court, then people won't do it if they are involved in a culture about status. But it became acceptable to do that. So alternatives, and we know with bullying behavior, alternatives often executed by peers with the support of adults can make a huge difference. But the cultural expectations, the alternatives that are respected are places where we need to do a little bit more work. I want to talk about the relationship between gang violence, peer violence, school violence, intimate partner violence. I know in the context of the pandemic, there is some evidence that intimate partner violence increased. And the National Commission on COVID-19 and Criminal Justice released a report back in February that was a review of 12 studies cutting across multiple cities. And the conclusion was that there was an increase in domestic violence incidents by 8%. In this particular review, they also included reports that didn't just rely on police reports, but looked at hospital records, health records, hotline registries, that kind of thing. And so they concluded that the pandemic and the lockdowns likely exacerbated factors that can be associated with domestic violence, increased male unemployment, stress from childcare and homeschooling, financial insecurity, increased use of alcohol and other substances. One of the things that we've learned in this notion of the cycle of violence is that the kid who's watching, from the closet, listening or watching under the sofa, violence at home, is in the thick, either as subsequent violent behavior emerges or subsequent victim behavior or victim experiences emerge, or some cycle of victim, perpetrator, victim, perpetrator, victim, perpetrator. But those children are in the risk, or are in the thick and at risk. And we see them. We're stitching them up in emergency rooms. We see them in the courtrooms when their siblings are being tried. We see them in school when they are misbehaving. And they are particularly at risk to a cultural set of messages that condone and encourage violence. So we have a lot of work to do. I remain hopeful because I know, like that blue line of car crash mortalities that declined, that red line can also decline. But it has to be a collective. It's got to be public health, criminal justice, law enforcement, education, clergy. We've got to all be at the table. and it's got to be sustained, even beyond a 10-year weapon ban. We've got work to do. So with that, I will close out and thank you again for the honor of speaking with you and open it up for questions.
Great. Thank you. Thank you, Doctor. That was riveting, I think. Thank you so much. So we have gotten a few questions, and I'll read the first one to you. It's clear that violence and its causes impact health status profoundly, but public health agencies are often siloed and specialized. What best practices have you seen, or what advice do you have for how public health staff can engage in violence prevention?
So that's a very good question. I think the place where I start when I have a problem to solve is to see what is similar that can be a model for the strategies or the interventions that I need. And while we have a ways to go on issues of intimate partner violence or even child abuse, I think as a collective, as a medical, law, social work, and public health collaborative, we've got some models there that would apply to some of the issues of peer violence. So in the emergency room, now, for intimate partner violence and for child abuse, there are protocols that are not only reimbursed by providers, but are widely used, and even to get your hospital accredited by the Joint Commission, you have to have those protocols. With peer violence, with other kinds of violence that don't fall into that clear victim perpetrator context, we don't yet have those protocols. So I would raise HAVI, HAVI, and I believe it's Hospital Association for Violence Intervention, but that is a group of hospitals. Actually, many of them are trauma surgeons who have said we need some protocols, and we need some protocols in the emergency rooms. And so their models I would bring to your attention, because when we're talking in the thick, which is really where I would focus funding and attention, we have to have that collaboration, and we have to get the providers connected to public health and to other resources. And that's what HAVI is doing. So I would raise that as a model. I mentioned in my talk, Big Brother, Big Sister. And I don't know, I suspect there are some pediatricians who write prescriptions for Big Brother, Big Sister in their visit. And I don't know that public health has really fully embraced Big Brother, Big Sister as a intervention, but it's certainly one of the blue ribbon interventions with this evaluation where they took kids off the waiting list and assigned them randomly, showing to having a Big Brother, Big Sister or staying on the waiting list, and showing remarkable changes within 6 months on about 15 variables. So with that kind of evidence, we shouldn't have underfunded Big Brother, Big Sister. We shouldn't have a waiting list for a Big Brother, Big Sister. Courts should, what is it when you make somebody go to a drug treatment program, should make kids go to Big Brother, Big Sister. I guess what I'm saying is there's a lot that we know that we just haven't taken to scale. And that's probably one of my biggest frustrations. There's great data that it matters in schools if you have universal violence prevention education. By universal meaning not picking out bad kids for violence prevention, but doing that kind of conflict resolution work for everybody. Fights are reduced 20 and 30% in this meta-analysis that looked at about 40 different situations. So there's part of me that's a little frustrated that we haven't taken to scale the things that we know could work and could make a difference. We still have situations where the child abuse prevention people in the hospital sit right across the hall from the intimate violence prevention people or response people. And there's not the collaboration. There's not the platform for joint work. For example, some shelters refuse to take women who have sons over the age of about 10 or 12 because they are afraid that those sons have the behavior of the batterer. So I understand that. At the same time, isn't that the perfect opportunity to do something other than exclude the person from the treatment? I think we've got to challenge ourselves within those silos to think differently, to think about the things that we're doing that don't make sense. And how is it that we can move ourselves beyond that? How is it that we can get our knee off the neck of people? Because it's, for me, the metaphor that makes it clear that as a physician, as a public health practitioner, there are things about my profession, there are things about my protocols, my thinking that really are not helpful. And how do I challenge that? How do I make it different? So that's a challenge I put back to you. And there are some models out there that I think you would find helpful.
Great, thank you. Let's see, I am going to read this one now. I think the language we use has real impact, and I'm wondering how we can go about making a change within public health. It isn't only DOJ and law enforcement that use terms that emphasize legitimacy of certain homicides with terms like justifiable homicide. And I'm going to take the liberty of asking you something that I always wonder about because I think it's related. Why does the media persist in saying these romantic descriptions, lone wolf, the gunman, shooter? Why aren't they required to say the coward, the child killer, the murderer of people without weapons? So I'm going to tag that on.
Well, I agree that language is extremely important. And over the years of working on this issue have adjusted things that I say accordingly. I'll give you one example. We did a lot of work with parents whose children had been murdered. And Tina Cherry in Boston, whose son was killed, this now about 25 years ago, started with her ex-husband, the Lewis Brown Peace Institute, and they have a march on Mother's Day every year in Boston. But one day, I said something, I think I was introducing her, and I said, and she lost her son in 2 or 3 years ago. This was when we were actively working on violence. And Tina turned to me and said, I didn't lose my son. My son was murdered. If I had lost my son, I would go find him. And, I now use the word murder in my description of these situations. it is important what we say. And this notion of justifiable homicide is really an example of the language that is a part of the Justice publication. It's been there since the beginning. And are there some situations with a police officer where a homicide is justified? Yes, I can imagine many of them, and I suspect some of them fall into that category. But even then, I know violence is never the best response to a situation. I guess I'm going to tell a story here about my experience after 9/11. It was 2 weeks after 9/11, and I was scheduled to fly to Ohio from Boston to give a speech. And I was trying to decide whether to go. Planes had just started flying again, and I sort of convinced myself, okay, look, this is, the time to fly, because everybody's paying attention to security. It's going to be safer now than it ever will be again. And if you are ever going to fly again, you might as well fly now. I mean, it just made sense to me. Intellectually, I agreed with myself and got on the plane. Well, there were only about 3 or 4 people on the whole plane. And when I sat down and buckled my seatbelt, I just was overcome with fear. I started shaking, I started crying. And then the thought that came to my mind was, okay, President Bush, you're supposed to be the hawk. You're supposed to kill people. I want these people dead. I want to be able to fly without being afraid. So needless to say, kind of have it now an out-of-body experience, like, okay, who is this person asking to bomb people? That, who is this? Over time, I got myself back together, but it was one of those aha moments when I appreciated what fear adds to a situation. And so, do police officers get afraid? Sure. Do stereotypes and racism and historical practices exacerbate fear in situations where it probably is unwarranted? Sure. I think we all saw the video of the Army lieutenant in uniform being, abused by police officers. He drove all the way to a gas station because he wanted to be in the light when he stopped. And I think we have to understand each other as we move forward in dealing with this issue. And even in the context of justifiable homicide, which clearly needs to be researched. Clearly, we need some epidemiology on this issue tomorrow. And I've seen a little bit coming out now, but body cams, and we're getting some information that was long overdue. And, for the first time, police are being prosecuted and tried and charged and found guilty for killing unarmed Black people. That's historic in the eyes of this community. So, there's a lot that has to change relative to the professional practices, and language is a part of that we use to create the other, or to distance ourselves, or to justify some of the things that make no sense that we continue to do, like stitch people up and send them out. There's data that if you save a kid from a gunshot wound, the mortality rate in 5 years is something like 20%. So we know it's not that we don't know. It's not that we don't have contact. We just have to do some things differently.
Here's another one. Educating persons to not commit violence seems like a downstream intervention. Would reducing poverty through government spending have a greater impact by preventing the conditions that predispose persons to violence?
I think the exposure, the work to prevent poverty is a huge violence prevention strategy. I don't have it behind me, but I have a bumper sticker that says poverty is violence. But I don't look at it as an either or. And the reason I don't is because there are so many situations where young people are employed as part of a program or an intervention. And a lot of what has to be done there is acculturation into what it means to have a job and how you handle anger and how a boss could sound like a bully, but really they may not be. They may just be explaining to you what needs to be done. So I don't look at it as an either or. Would I start by 100% employment and then work on cultural issues? Yes. But the reason the cultural issues are so important for me is that the homicide rates of elite white gentlemen, these were enfranchised people with resources. That was by definition. So I try to avoid a kind of either or. Obviously, when you have dollars for a program, you have to decide where to begin to put them, or if you're doing public policy with government dollars, you have to decide where to put them. But we should make racism go away. I mean, we should make poverty go away. We should make racism go away. But the reality is there are people in this society who experience those things on a daily basis, and helping them process it and overcome it is also very important, because that's what parents try to do on a regular basis. That's what has changed things. And then, I don't want to be skeptical of the possibility of an economy that is, equal and fair, and, employment is full. I mean, I don't want to be skeptical of the possibility of a society where we are literally judged by the content of our character and not the color of our skin. I'm not skeptical about that. But I also know that on a day-to-day basis, what helps people handle those things is also very, very important. And I'm going to tell you why I'm not skeptical about it. I mentioned the work that we did with parents whose kids had been murdered. One event was a bringing together of 150 such parents. We got a General Mills grant to bring together parents from all over the country who had experienced the murder of a child, and many of them were trying to start local organizations. And we had Mothers Against Drunk Driving in mind as a way of bringing them together. Helen Bassett in Minneapolis is still at it. She's having some kind of conference back in January. This was oh, I'll have to remember exactly when it was, but I think it might have been early 90s, 96, 90s, maybe mid 90s. But anyway, the first event, the first gathering, this was a weekend in Chicago. The first gathering, we had people assigned to tables and talking, and they were Black, they were white, they were Latina, they came from all over the country. It was powerful. And then they started sharing stories. And that was the first time in my entire life, and to this day, the only time that I saw race and class become non-issues. These people had such a bond over the horrible thing that had happened to them that I thought, oh my God, this is possible. It is possible for us to move beyond this constant look at, race and class in the face and appreciate that it has so much to do with what happens, what we do and how we do it. And in that, for that moment, it was so powerful. Now, I just hope that we don't have to have such a horrible tragedy to have that level of awareness. I mean, we talk about 9/11 and post 9/11 and what it meant for us as a country. This notion of a common enemy or the hurt of a common tragedy. I hope it doesn't take that. But I'm not skeptical because I know as humans, we have the capacity to do it because I saw it. I saw it happen without any intentionality. Mm-hmm. It just, these people came together, immediately started sharing, and the bond was thick.
Oh. All right, I'm going to ask one more question.
Okay.
Time allows. I think it's related. There is some evidence that child maltreatment is underreported by clinicians who don't want to become engaged in the time-consuming and challenging process that can follow a report. What changes would you recommend to encourage more comprehensive reporting?
That I would really have to give I'll tell you how I would approach answering that question, because I really don't have the answer. But I think that getting outside of the box is difficult for professionals, whether it's issues of time or issues of vulnerability around being blamed or held responsible. So I think it starts with a conversation that allows the time issue or any other issues. You raised the time issue and just kind of getting caught up, or any of the other issues, to be put out on the table and understood and addressed. It may mean that the role has to be transferred to an additional person. There are lots of examples in our day-to-day administrative lives of saying, okay, this role, if we split it out or if we add this person, that will help.
Great. Yeah.
So that's kind of my response, really just the process I would go through, but I don't know even models that have addressed that question.
Well, I just want to thank you. I know we're running out of time, so I don't want to run out of time for the thanks. This was just a great keynote, a great Q&A discussion.
Thank you.
I only wish we were in Baltimore and I could give you a timely, non-socially distanced hug. And so I'm going to thank you. I'm going to thank all in attendance. I want to say be sure to check out 2 more sets of great sessions this afternoon, followed by speed networking and evening roundtables. Tomorrow, there are more choices for not to miss sessions, morning and afternoon, a closing plenary on young leaders in health, equity, and justice at 11:30, followed by a town hall at 4 on the assault on public health authority to act for the collective good, confronting the danger. And while I have your attention, and I hope I have the time, since I won't be a plenary introducer again, I just want to thank all our sponsors, all of the attendees, all of the network's conference planning committee, and the network's small but mighty national office led by the incredible Anne-Fee Went. And now onward to the rest of the conference. And thank you again, Doctor.
My pleasure. Thank you.
Take care.
All right. Bye-bye.
Bye, all.